minded, I would call this the most logical of all chapters, because everything that we talk about today and the next session, I suspect we'll finish this in 2 or 3 sessions. There's going to be a small lab also, only about 15 cases. So that's why I put the straw up there. If you consider a straw a blood vessel and you're sucking in on it, there's only 2 bad things that could happen to that straw. It could get clogged or it could rupture. And basically, the whole spectrum of vascular diseases today result in one of those 2 events pathophysiologically. So it's the most logical of all chapters. I won't call it the most interesting or the most exciting. I know it's hard to get excited about blood vessels, but we're going to do the best we can. This is our thing that we put on Facebook, like we are putting things on Facebook every day now to give you a preview and a recap of the sessions. These are blood vessels, and we talk about disease of the blood vessels. And as you remember, way back in Chapter 1, I said that there are only 3 kinds of diseases from the point of view of a regular old anatomically minded pathologist. There are degenerative diseases, there are inflammatory diseases, and there's neoplastic diseases. And that's pretty much how not only this chapter will be organized, but all of the rest of the chapters on systemic pathology are organized that way. There's always one little thing at the beginning which doesn't quite easily fit in with those 3 categories, and I think it's a pain in the butt because I would like to think in terms of simple 3s. But in almost all of the chapters, including this one, there's this, usually the first session is on congenital diseases or malformations, and we're going to throw that in easy because it doesn't quite easily fit in with the concepts of degeneration of blood vessels, inflammation of blood vessels, or neoplasms of blood vessels. Let's review our basic histology. And as you know, the entire cardiovascular system, all the way from the heart down to the smallest capillary and back again, is lined by a very special kind of cell called an endothelial cell. It is a flat cell. I guess you could call it squamous because it's flat, and you can see one over there, and you can see the nucleus of endothelial cells just about everywhere if you look good enough. And of course, when you're down at the capillary level and you see a couple of red cells squeezing through a little space, if you see a little crescent-shaped nucleus at the periphery of one of those red cells, you know that's the endothelial cell. And of course, now the difference between these 4 entities, heart, artery, vein, and capillary, if you want to be simplistic about it, is that the heart has a wall of striated cardiac muscle. The arteries have a wall of smooth muscle. The large elastic arteries in aorta, not only do they have smooth muscle, but they have elastic fibers, which are very squiggly, and you could even see those pretty well on routine H&E stains. You don't always need a good elastic stain for it. Here is an elastic stain over here, in which you might be able to see the external elastic lamina on these arteries. But the only difference between any tubular structure in the entire cardiovascular system is how much or how little muscle there is surrounding those endothelial cells. So in arteries, the artery half of the circulation, the general rule is that the smooth muscle cells and or the elastic fibers and the smooth muscle cells are generally thicker than the surrounding adventitia. Remember, the endothelium is the intima and the immediate connective tissue beneath it, no matter where you are. And then the media is the muscle and or elastic tissue. And then the adventitia, the third outer layer, is the connective tissue, chiefly of loose connective tissue and collagen. Now here's the general rule. In arteries, the muscle is thicker than the adventitia. In veins, the adventitia is thicker than the muscle. So here, let me say that again if I didn't say it right. In arteries, the media is generally thicker than the adventitia. And in veins, the adventitia is generally thicker than the media. So like even in the very, very largest of veins, like the vena cava, the amount of smooth muscle is relatively small, never than a couple of layers. Okay, another thing to remember is that in arteries, there is a internal elastic lamina, which separates the intima from the media. And usually there's an external one as well, which stains nicely like on this elastic stain here. But you don't normally see them very well on H&E. And of course, almost the entire layer of this aorta is elastic tissue. And if we did an elastic stain, it'd be as black as hell. But what it looks like on regular H&E is kind of white and squiggly. Those are elastic fibers. So, of course, you can think of a capillary as being basically nothing more than a single endothelial cell arranged in a circular fashion so red blood cells can squeeze through. And of course, they can have little holes in them. They could be fenestrated or they could be non-fenestrated. So that's our basic review of the anatomy and histology of the cardiovascular system, emphasizing blood vessels more than the heart. We'll do the heart on the next chapter. And also remembering that no matter what you're dealing with, you have to have an endothelial lining cell on the lumen for it to be a blood vessel. And also remember, most of the diseases that we'll be dealing with in the next couple of sessions will be diseases of arteries rather than veins. Okay? But we'll also pick up a little bit on the veins at the end too. So here are the components. You have your intima, media, adventitia. Okay? In a artery, the media is generally thicker than the adventitia. In a vein, the adventitia is generally thicker than the media. That's a rule of thumb. It doesn't always apply, but I know sometimes when you're looking at vessels, even, and you know, they could fool all of us. I'm sure that every day Dr. Betty and I look at tissues and we say, well, I'm not too sure if this is an artery or vein, but in most cases we don't care. They always have to have endothelial cell, the most special type of cell that has to line every type of blood vessel. In arteries only, the internal elastic lamina, the internal elastic lamina separates the intima from the media. In the media, you chiefly have connective tissue, chiefly smooth muscle cells. In the larger arteries, the so-called elastic arteries, which are direct branches off of the thoracic aorta, you have a significant amount of elastic fibers. In the aorta, it's almost entirely through the whole wall of the aorta. In the elastic arteries, it may be just half of it or less than half. But in every artery, you need at least one nice elastic lamina separating the intima from the media. Very often, in most of the cases in arteries, you have an external elastic lamina also. Interesting that we always think of generally a smooth muscle as being contractile. In the media of arteries, very often smooth muscle makes a lot of connective tissue as well, the mucopolysaccharides, and also it does a lot of migration back and forth. And one of the non-specific features, not only of atherosclerosis, but just about every type of arterial disease in which there's intimal damage, is that smooth muscle cells just love to cross that internal elastic lamina and go into the intima. And of course, on the outside, there's generally boring, loose connective tissue, maybe a little bit of fat. And those are all the components of the cardiovascular system. Once again, from a functional point of view, from a clinical functional point of view, I can't think of a single disease we're going to be talking about in the next couple of days in which clinically and functionally the endpoint is not either blockage of that tubular vascular structure, of course preceded by narrowing. You know, of course it could block suddenly as well if there's a quick outside or even inside compression, or rupture of the wall. And the ruptures of walls of blood vessels are usually preceded by weakening, unless, of course, it's traumatic as well. So, if you want to talk about vascular diseases, we're talking chiefly about arteries. And if you want to talk about vascular diseases, about arteries, there's basically only two topics to talk about. Number one, atherosclerosis, the number one killer of mankind. And number two is everything else. So we'll spend most of today talking about atherosclerosis. The thing I wanted to point out is that there's going to be a lot of repetition, because when we talk about the natural history of atherosclerosis, we're really talking about its pathogenesis as well. So if it sounds like I'm being repetitive graphically and verbally and conceptually, that's intentional, because that's the way it's organized. But I also think that when we look at the sequence of events, like we looked at the saga, sequence of events and inflammation, or the saga, the sequence of events and coagulation, we'll basically be looking at the saga or sequence events in atherosclerosis as well. So here are the topics, and this is the way the chapter is organized. We're going to talk about non-specific vascular wall responses to injury. And when I talk about that, you're going to be saying, gee, that sounds like atherosclerosis. And it is, but remember, the way a vascular wall responds to injury is basically what happens in atherosclerosis, only it's a non-specific response. We'll talk about the congenital anomalies, okay, the thing that doesn't always fit in easily, to degeneration, inflammation, or neoplasm. And then we'll be talking about the degenerative diseases, atherosclerosis. How is that different from arteriosclerosis? We know that arteriosclerosis is a nonspecific term, and it refers to hardening of arterial walls due to any reason, whereas atherosclerosis is more specific. And even though there is not one single unified, agreed upon, precise etiology, we all know what we're talking about. It's a deposition of fatty substances and plaque, and eventually calcification in the wall of arterial blood vessels. We'll talk about what happens in hypertension, aneurysms. Almost all aneurysms are the result of atherosclerosis, but nevertheless we'll talk about them separately as well, because there are other causes. Then we move on to the inflammatory diseases of blood vessels, the so-called vasculitides. And whereas inflammations of almost all other organs very often have very specific pathogen causes, like viruses or bacteria, almost all of the vasculitides, or the primary inflammations of blood vessel, or more specifically arterial walls, do not have an external pathogen etiology like a virus or a bacteria. So that's why they generally fit in the category of autoimmune diseases. And we talked about autoimmune diseases. We already referred to several of the vasculitides, but we're going to be talking about a few more. We're going to talk about a clinical phenomenon, not really a disease, called Raynaud phenomenon, a very common thing. We'll be talking a little bit about the neglected, thin-walled, thin muscular-walled parts of the cardiovascular system, and with the adventitious greater than the media, the veins. And we'll say a few words about lymphatics, which are basically very, very thin-walled. If you think veins are thin-walled, lymphatics are even much thinner. Very often, absolutely no connective tissue in the wall. We can't neglect the tumors, and in most chapters, this is no exception, the tumors of blood vessels are usually mentioned at the end. It's kind of funny, because tumors are almost at the end of all of the systemic chapter topics, but they're always a first concern to pathologists. So we have to really hold our breath and bite our tongue a little bit until we get to tumors. Then we'll say a few words about so-called interventions like stents and bypasses, and some of the vascular effects of those as well. Let's get into some definitions first, so we all know what we're talking about. These are all easy. Some of them I mentioned already. Some of them you already know. Arteriosclerosis, non-specific term. It means hardening of the arteries due to anything. Okay? Now, most arteriosclerosis is atherosclerosis, or hardening of the arteries due to the deposition of atheromas. An aneurysm is a ballooning of a vascular wall usually preceded by weakening of the wall. Dissection in a blood vessel refers to the passage of blood throughout layers of the vascular wall, which is also related to weakening and also associated with aneurysms. We all know what a thrombus is. We spent several chapters on it. That's a blood clot. That is a blood clot that forms within a blood vessel wall. We'd spend a lot of time on that. We all know what hypertension is. It's increased arterial pressure. And to make things very, very, very simple, if a sustained systolic is greater than 140 and or a sustained diastolic pressure is greater than 90, sustained, that's hypertension. Simple as that. The vasculitides are the same as the various vasculitis is, and even though most of them are non-infectious, in other words, we can't identify specific external pathogenic antigens causing those inflammatory reactions, so a few of them are. Varicosity is a term applied chiefly, in fact exclusively, to vein. And when we talked about dilatations of veins due to increased pressure and tortuosity of veins due to increased pressure, perhaps secondarily with some fibrosis and thickening and even calcification of the wall. These are varicosities, okay? And chiefly they are in the legs, but technically, even if you had a portal vein with increased pressure, a varix, esophageal varices, that would be a varicosity as well. DVT is a thrombosis of a deep vein, and those refer to the deep veins of the lower extremities, the calves and thighs, as well as the deep veins of the pelvis. Okay? Otherwise, thrombophlebitis is exactly the same as phlebothrombosis. They're pretty much identical terms. Phlebothrombosis is almost never used, however. Thrombophlebitis is usually used rather than phlebothrombosis, and the itis implies perhaps a secondary inflammatory component, perhaps even clinically evident within that thrombosed blood vessel. And of course, in this case, phleb means vein, so we're talking about thrombosed veins rather than thrombosed arteries. If they're deep, we call it DVT. Couple more definitions. Lymphangitis is technically inflammatory changes associated with lymphatic vessels. Usually this is limited to inflammatory cells within these extreme thin-walled vessels. Lymphedema, we've several examples of already. Anything which injures a lymphatic vessel, such as inflammation or filling up with tumor cells or radiation or trauma from surgery, would result in the accumulation of fluid proximal to those channels, and that's called lymphedema. Angiomas and hemangiomas are generally generic terms referring to benign blood tumors of blood vessels. There's probably 30 or 40 or 50 specific tumors, benign tumors of blood vessels I could think of, but in general, they could all be lumped into the general category of angioma or hemangioma. If it was technically a benign tumor of lymphatic tissues, it would be called lymphangioma. And using the classical terminology we learned about in the chapter on neoplasm, if it was a malignant proliferation of blood vessels, it would be called angiosarcoma. That's the generic name. There are many different types of specific malignancies of blood vessels. And of course, theoretically, a malignant tumor of lymphatic vessels would be called a lymphangiosarcoma. Now, before we get into the big topic which we'll be spending most of the day on, atherosclerosis. Okay, the thing that is really the single most important, perhaps only really important thing that you'll all be dealing with every day, not only in your patients, but in your own lives. We'll talk about some non-specific vascular wall responses to injury. Now, do you remember way back when several times we described endothelial cells as being like Dr. Jekyll and Mr. Hyde? Remember, that was a guy that was a really nice guy, Dr. Jekyll. But when he went crazy, he turned into a ruthless killer. And that's how I always think of endothelial cells, because endothelial cells in your body are the most wonderful things to make sure that blood flows nice and smoothly and it doesn't get clotted. And when the endothelial cell, however, or the part of the blood vessel wall that's the interface with the liquid blood, gets activated, it does a whole bunch of things to do exactly the opposite what the endothelial cell does before it's activated. We'll talk about the role of smooth muscle cell, and in general, smooth muscle cells react. Now, we think of smooth muscle as basically boring cells that kind of contract involuntarily. We don't normally think of them in terms of producing extracellular substance or collagen or migrating very much in the vascular wall response to injury, but smooth muscle cells do a lot more than we normally expect. If you remember, we spent a couple of days talking about inflammation, repair. We use several terms for the remodeling of blood vessels. We use the word neovascularization when we talked about the ingrowth of new blood vessels following acute inflammation and repair. We also used the term organizing inflammation, which is the ingrowth of blood vessels following inflammation. We also use the word granulation tissue. And so far, everything I mentioned here is the same thing. And to make it even more interesting, the term angiogenesis is also used to talk about the development and growth and remodeling of blood vessels following vascular wall injuries, and not only vascular wall injuries, but also any non-specific inflammatory response in the area that that blood vessel is feeding. So, what am I trying to say? Neovascularization, organization, granulation, angiogenesis, they all mean the same thing. Now, the thing that is almost present all the time in a vascular wall injury is damage to the intima. And that would make sense, wouldn't it? Because that's the area that's at the interface with the blood. So anything that is happening inside the blood vessel is going to result in damage or activation to the endothelium. And as this process evolves or progresses, like the inflammatory saga, it will result as intimal thickening. Now remember, these are all non-specific vascular wall responses to injury. They sound like the saga of atherosclerosis in general, but it's not. It's a non-specific vascular response. We're going to have to give you a yellow slide here, which means, number one, there's a lot of junk on it, but number two, I think you should really know all this stuff. That's why I put the yellow background. And if you recall, once again, the Jekyll-Hyde concept, you know, in the resting, unactivated state, the endothelial cells do a lot of things to maintain hemostasis, which is the opposite of coagulation, right? Now, when they're activated, they then do a whole bunch of other things to cause or enhance thrombosis. So what are the things they do when they're Dr. Jekyll, the nice guy? Well, first of all, obviously, anatomically, they maintain the permeability barrier. They are the interface. They are the only cellular interface between the liquid blood and the blood vessel wall. Now, if you remember, in the unperturbed state, they have a variety of anticoagulant, antithrombotic, and even fibrinolytic properties. If there is a clot there, there's things that it'll do to dissolve that clot. And those are compounds like prostacyclin, thrombomodulin. Some people say heparin, or some people say heparin-like molecules. I don't think it matters, but it acts as an anticoagulant in a resting state. And plasminogen also, remember, that's part of the fibrinolysis system. So if there is a constant tendency towards thrombosis, there's enough plasminogen there to make sure that's dissolved. And remember, it also, in the activated states now, elaborates prothrombotic molecules, or molecules that will start to enhance or amplify coagulation. One of them is von Willebrand's factor. Remember, that's the guy that connects the platelets to the extracellular matrix. Tissue factor, which is the main initiator of coagulation and the quickest way for blood to clot as well as plasminogen activator inhibitor. So on the one hand, when it's resting, it makes plasminogen to promote fibrinolysis. When it's messed with, it makes a plasminogen inhibitor, which is the opposite. So that's what I mean about the Jekyll and Hyde concept. Endothelial cells also have a lot to do with the formation of the extracellular matrix in terms of collagen and proteoglycan substances, which of course are deep to the endothelial cells. Remember, there's a little bit of connective tissue underneath those epithelial cells. There's a little bit of ground substance or extracellular matrix. And then you get to the internal elastic lamina, and bingo, you're no longer in the intima. You're now crossed it, and you're in the area where only smooth muscle cells should be. Endothelial cells make endothelin, an angiotensin converting enzyme. Remember that? These are very, very powerful vasoconstrictors, and they're done as a response to injury. Isn't that logical? You injure a blood vessel, and it makes things to constrict that blood vessel so you don't bleed to death. And that's before the coagulation may or may not start. It also has properties which promote, as another mechanism for control, vasodilatation. One of those is nitric oxide, one of the most powerful vasodilators around, natural, as well as prostacyclin. Okay, we also remember generally that the endothelial cells migrate into inflamed areas, and they start the production of neovascularization, or if you want to use one of the three other terms you can. Remember, they're regulated by a wide variety of growth factors, of which endothelial growth factor and half of the other growth factors are on the list. And they also oxidize low-density lipoproteins. Now, what are the things that actually activate the endothelial cells? What are the activators? Well, we talked about some of them already, and in Virchow's triangle, you know, one of the powerful forces are hemodynamic forces. If there is a change in force or a turbulence of flow or a stasis of flow, this is strictly a hemodynamics force, and that in itself could activate endothelial cells. Remember, in shock, when there basically is no flow, those endothelial cells are now sitting against a wall of blood which is not moving. That's also a very powerful activator. There are products in bacteria called endotoxins or lipopolysaccharides, which you have here as a lipid product. There's a wide variety of cytokines which activate endothelial cells. And without going into the differential, just remember many viruses doing it. In many of the viral and bacterial pneumonias, you see prominent vasculitis as part of that. What about complement? Remember, when complement is fixed, it can lyse the membranes of cells. Well, endothelial cells are no exception. And also remember, hypoxia itself, or a lack of oxygen, even if there is no hemodynamic force, can also be an activator. So it doesn't take very, very much to turn Dr. Jekyll into Mr. Hyde. And of course, I wouldn't be fair if I didn't throw in cigarette smoke. We said a whole bunch of things about tobacco the other day. But it's very, very fact that cigarette smoke itself is an endothelial activator. Okay, what about the next layer beyond the internally elastic lamina and artery? What about the smooth muscle cells? Well, we know in veins this is just a usually very thin layer. So the role of smooth muscle in arteries is much more important because it's much thicker. It is the primary thing that causes vasoconstriction. Remember the simple geometric fact that the smooth muscle cells are arranged axially around the axis of the flow of blood. So if you took that soda straw and you have blood flowing through it, these smooth muscle cells are arranged like wrapped around it the other way. So for a smooth muscle cell to constrict, it means the muscle constricts. For a smooth muscle cell to dilate, it means the whole blood vessel dilates. Okay? Also remember, vascular smooth muscle is much more than just a little guy that squeezes under a variety of conditions. It also makes collagen. Isn't that interesting? It also has a role in making elastin. It also has a role in making the extracellular matrix, very big component, the proteoglycans. Remember, these are coming from smooth muscle. Don't forget that, because we normally don't think of smooth muscle as doing it. And smooth muscle may do it in other parts of the body. I'm not too sure. But in blood vessels, it is the chief thing that does it. There are a variety of substances that regulate vascular smooth muscle. And I'm just going to put in the top 3 or 4 for each one. One of the big promoters or initiators of smooth muscle constriction is platelet-derived growth factor. And also, remember, we talked about that factor derived from the endothelial cell itself, the endothelium, as one of the first things to constrict the smooth muscle cell and therefore constrict the vessel after a nonspecific injury. Thrombin can also result in constriction of a smooth muscle cell. Fibroblast growth factor. You know what, I looked on the list and there were about 10 other things, but I just wanted to tell you like some of the main ones. And I did not make this a yellow slide, but maybe I should have. Heparin, not heparin that is made by the endothelial cells, but the heparan sulfate is an inhibitor of smooth muscle contraction, and therefore it will result in smooth muscle relaxation and vascular dilatation. By the same token, nitric oxide is one of the greatest smooth muscle relaxers and therefore vasodilators. And also transforming growth factor beta. We looked at our long list of substances, the growth factors. We said TGF-beta was a very, very significant vascular smooth muscle inhibitor as well. I put a little bit of information. This is almost directly a cut and paste from Wikipedia at the bottom in case you wanted a little bit more information about this stuff. Now, let's make a general comment here about vascular growth and remodeling. Because remember, we're really talking about two processes. Number one, we're talking about a reaction of a damaged blood vessel, okay, no matter what that damage is. And that's the process of vascular growth and remodeling after damage. But also remember, we're talking about practically any injury process in the body, even if it's not a specific vascular injury, any inflammatory, any regenerative process also is associated with vascular growth and remodeling. So let's define it, and we'll just, keep it at that. And I probably got this from Robbins, I'm not too sure. But vascular growth and remodeling is defined as the sum total of all the factors and processes, I'm just reading this, involved in tissue injury and the body's ability to grow new blood vessels, develop new pathways, and reperfuse areas in response to tissue and or blood vessel injury. So all of this growth and remodeling not just occurs with blood vessel injury, but tissue injury. Because you can't damage tissue unless you damage blood vessels. And I could say probably the opposite is true as well. So let's look at this non-specific response. And we're talking about vascular injury and some of the things. Well, I like this graphic here because it shows what you'll never really see in real histology. You've got nice endothelial cells just laying in continuity with other little junctions with each other. They have nuclei. Of course, if you're looking at this under a real microscope, you'll be lucky to see one or two of these nuclei. And that's the endothelium. Okay? Now remember, there's a little bit of connective tissue underneath that endothelium. And then you have the internal elastic lamina, if you're an artery. And then on the other side of that is now the media of the artery, in which your predominant population is smooth muscle cells. But remember, the smooth muscle cells aren't just sitting there squeezing, they're also making a wide variety of matrix compounds. Now, in a non-specific response, these smooth muscle cells breach, they cross, they migrate through the internal elastic lamina. So if you see smooth muscle cells on the luminal side of the internal elastic lamina, there's a good chance that that vessel has been injured. And in addition, because these smooth muscle cells elaborate extracellular matrix, they're much more likely to make it once they're activated or migrated through the intima, through the media and in the intima. Okay, now they can make it here too, but if you looked at 1 million blood vessels, you don't normally see hardly anything but nice smooth muscle cells in the intima. Once those cells cross into the lamina, cross the internally elastic lamina, you're going to see a whole bunch of connective tissue and ground substance and proteoglycans, blah, 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 blah. And also, remember, they're more likely to be dividing. Remember, smooth muscle cells are the only type of muscle cell that divides. The muscle cells that have striations, you know, the skeletal muscle, the voluntary muscle, the cardiac muscle, they don't divide, remember? Well, not only do smooth muscle cells divide, such that, you know, a 50-gram uterus can now be a 500-gram uterus, is because these cells are dividing. They're not just getting thicker, they're dividing. You have 10 times as many cells. And they're more likely to divide in the area that's injured on the other side of the internal elastic lamina. Okay, we're done with the nonspecific responses. And when we get into atherosclerosis, it's going to sound like I'm repeating myself. And I will be to a certain degree, partly because it's worth repeating. But the process of atherosclerosis is going to be very, very similar, because whereas this is a nonspecific response, atherosclerosis can probably be considered to be a relatively nonspecific disease as well, in absence of a very, very specific etiology. All we have are 4 risk factors rather than one single etiology. So, remember, the first part of general discussions of diseases are congenital anomalies, and the most common type of blood vessel congenital anomaly is in a situation when blood vessels are developing and for some reason there is a fistula. A fistula is defined as a connection between 2 tubular structures. For example, between a bladder and a rectum would be a rectovesical fistula. Okay, but in this case we have an arteriovenous fistula. We have a connection because of abnormal congenital development between an artery and a vein. Arteries are areas of high pressure, veins are areas of low pressure. So if you think that that vein adapts to the higher pressure by having more smooth muscle and more fibrous tissue in its wall, you're absolutely right. So if you were to look at an arteriovenous fistula, which by the way is also called arteriovenous malformation, Okay, they're exactly the same terms. AV fistulas are the same as AVMs, AV malformation. If you look at them, you're going to see that sometimes you're looking at what might have been vein, but it looks like an artery because it has a thick wall. But remember, the thickness of a blood vessel wall follows the same principle as the thickness of any cardiac chamber in the heart. The thickness of a blood vessel wall will be as thick as it has to be depending on the pressure. Okay, these fistulas between the arteries and veins are usually congenital. They can be acquired by trauma or inflammation in which somehow there is abnormal repair, but generally an anomaly or a malformation is almost always thought of as being congenital. And of course the radiologists, they call them AVMs, arteriovenous malformations. I never heard a radiologist call an AVM in the brain arteriovenous fistula. They all call them AVMs. They could be anywhere, of course. When they're in the brain, that's when they're of the most concern. So they're not limited to the brain. There could be technically anywhere. Okay, let's take a look at some of these guys. Here's a CT. Looks kind of boring, but you can tell it's CT because they're bone in the skull rather than a light signal. It's high density. And before they do the angiogram, you could generally see that there's some increased sort of density in this hemisphere, which is the right hemisphere. And it looks like there's some tubular continuation of this density, and then maybe either some calcification, or I don't know what's going on here. So they do the CT angiogram. They inject the substance, which causes increased density within that vessel. And look, it's almost like the whole half of a hemisphere is loaded with something that looks like it's tubular in areas, twisted in others. This is a classical AVM, AV fistula. Pathologically, artist's conception here is it a result of abnormal formation of blood vessels? Now, if you were to look at these things histologically, and I'm sorry, I should have put a picture in there, and you're looking, and we will have it in lab, by the way. There will be a few lab cases, and one of them is an AVM. You will see that some of the veins have a thick wall. Does that mean it's an artery? No. It just means it's a blood vessel that must sustain that increased pressure. Now, what happens if it can't sustain that increased pressure? Well, then it bleeds, doesn't it? The brain bleeds. So the most feared complication of an AVM anywhere, not just the brain, is that it bleeds. And that blood, that acute hemorrhage, can kill the patient. And I put a little movie of AVM on YouTube, and I already had like about 6 or 7 people that have emailed me and said, Dr. Minarsek, my mother, my sister, my aunt, died from one of these things. Another thing that it could do is have a pressure effect, because it may look like this twisted bunch of vessels is compressing the brain tissue around it. So it has a mass effect as well. So compression and hemorrhage are the 2 biggest sequelae of AVMs. Okay. Let's open the door to the big kahuna now. Let's start talking about the mother of all diseases. The disease that could cause practically any symptom. The disease which could affect any tissue of the body which is fed by arteries, which of course is everything. Let's talk about arteriosclerosis. Now, although the words, even in the medical literature, arteriosclerosis and atherosclerosis are used interchangeably, that's okay. I don't have any problem with that. But remember, arterio just means, sclerosis means hardening, arterial means artery. So anything that hardens an artery, whether it's abnormal deposition of calcium within the muscularis or within the media. See that I used the wrong term. I call that the muscularis. That's only for GI. It should be called media. That would technically be one form of arteriosclerosis, would be a condition called Mankenberg's medial calcific sclerosis. It's something you normally don't see too much. Sometimes you see them in the uteruses that have been taken out, in the arteries of them. They're usually asymptomatic. Nobody knows what really caused it, but you generally know that the calcium is usually the result of endpoint chronic fibrosis and inflammation of many, many years, and that's all we could say about that. The 99% of arteriosclerosis is atherosclerosis, the big thing that we'll spend the rest of the day talking about. Another term which I would like to introduce and differentiate is the term arteriolosclerosis. So it's just like arteriosclerosis, but we put in a little low in there. And that refers to the fact that the sclerosis is generally not in the bigger, the muscular, the distribution arteries, that it's more in the smaller arteries and arterioles. And that generally is used specifically with regards to the kidney, although technically an arteriolosclerosis would be a hardening of an arteriole. In reality, when you hear the word arteriolosclerosis, they're almost always talking about the kidneys, and especially kidneys in which hypertension has been present, or this condition actually causing hypertension because of renal ischemia, so both as a cause and effect, and of course in diabetes as well. Okay, now that we've differentiated arterio from athero, let's get into the big kahuna here. We'll make a few introductory remarks and then take our break. Well, here it is, 2012. We just celebrated the new year. We still don't know exactly what causes it. So that's why, like many of the diseases in which we cannot state there is a very specific etiology, the best we could do right now is talk about risk factors. And up until the Framingham study of a couple generations ago, risk factors were coming out the wazoo, and everybody had a theory and everybody had some evidence. But the really spectacular, groundbreaking thing that Framingham did is it really told you what the real major risk factors were. Okay, so atherosclerosis is a disease classically. If it doesn't have a specific etiology, it has risk factors, like we said in Chapter 1. We have a pathogenesis, or sequence of events at the cellular level, which happen in the development of the disease, and often way before the clinical expression of the disease too. We have the morphology, we have the plaques, we have the yellow streaks, we have the aneurysms, we have all the things you could see with your eye and with the microscope and with angiograms and MRI. And of course, we have the clinical expression of disease. And what's the clinical expression of atherosclerosis? Well, the clinical expression of atherosclerosis is disease in any tissue of the body which arteries feed. So that really opens up the door to a lot of things, doesn't it? Another thing I can tell you is that very often in medicine, when you go to grand rounds or you're studying patients, and you'll see a whole bunch of weird symptoms and you really can't quite put them together, and you get out your iPods now and you get out your Google and you open your books and you scratch your head like I'm doing right now, and you go, okay, what weird syndrome can this be? Well, can I tell you something? More often than not, it's just regular old atherosclerosis. So, these are the 4 classical features of all diseases. If you don't have them, you don't have a disease. This is how Robbins handles it. It's pretty much the same thing, but he expands it a little bit. The pathogenesis is very similar to the natural history when described the sequence of events. So that's what where the repetition is going to be. The epidemiology is very similar to the risk factors. There will be other factors, perhaps minor risk factors, abnormal lab tests. And not only will we be talking about the clinical expression or the effects, but we'll go into the prevention of the features as well. Now, isn't that funny? Because after all of this stuff, I'm sitting here, we already wasted an hour. We said we're going to talk about atherosclerosis today, and I can't sit here and tell you what exactly causes it. But I can tell you one thing for sure. It's always preceded by intimal damage of some type. So, here's where we're going to start. Natural history, very similar to the pathogenesis, and after our break we're going to go into the saga, the sequence of events that develops in the development of atherosclerosis. Okay, is going to conflict what I previously said. It's going to be looking at the most significant disease on the entire planet, perhaps in the same way from different eyeballs, and talking about the same events perhaps from a text point of view, a graphic point of view, a clinical point of view. And we'll start out with the number one aspect of atherosclerosis, the natural history. This is one way of looking at it. Okay, let's just say that in the first initial event you have migration of macrophages through the endothelial cells of the artery coming into the intima. They're foamy cells. The foam, or the tiny little microvacuoles within the cytoplasm of these macrophages. And remember, before they come in, they're called monocytes. But once they get in, they're called macrophages. They're the same cells. It all depends on what side of the endothelium they're on. That's the very, very earliest step, morphologically speaking, in atherosclerosis. When does it start? Look at this. The first decade of life. Not just kids, but weenies, okay, little kids. The first grossly recognizable lesion, which we can see at autopsies on young people, is something called a fatty streak. And all that is more macrophage foam cells filled with cholesterol, lipids. Perhaps lipids is a better term because it's not really pure cholesterol. Probably most of it is cholesterol esters. And it's intracellular, and it's in the intima, and it looks yellow. You can't feel it, but remember we said that every single thing in the body that's yellow is fat, and everything in the body that's fat microscopically is not yellow anymore. It's washed out because in the processing of slides the fat gets dissolved in the xylene. Okay, what would be considered type 3 if you want to divide this into 6 chapters? Well, these macrophages are now starting to dump all of their lipids outside the cell and forming small pools. You call this number 3 if you want, and it's a progression from 1 and 2. And now, in the average person that's at risk for atherosclerosis, you're getting into the 3rd decade now. We're talking about in the 20s. Once you could see the streaks and the pools, you are now in the 30s. I'm sorry, 3rd decade is 20s, isn't it? Next stage is a logical stage because it's just a further accumulation of these lipids, chiefly in the intima, which you could now feel. So an atheroma, when you do an autopsy, it's something that you could feel even if you were blind. If you can only see it because you're not colorblind and you know what yellow is, those are the fatty streaks, okay? So you want to call the atheroma. The first palpable, feelable with your finger type of disease is already at the 4th stage out of 6. Now, the atheroma acts as an irritant. It can become calcific with enough chronic inflammation and fibrosis, but the main tissue response to atheroma is fibrosis around that lipid pool, okay, and it could then become calcific or fibrocalcific. And not only are atheromatous lesions hard, but they can be, you could hear them when you cut them because the scalpel goes. Now in this stage, it's an accelerated phase, and now there's more smooth muscle migrating in to the intima from the media. There's more collagen, and like anything in the body, when there is an inflammatory response, which of course this is, You can then end it with fibrosis. You could then end it with calcification. Now, let's talk about the last, or the most advanced stage. Is not only do you have something that's palpable and something that's been reacted to with an inflammatory response of calcification, fibrosis, but this material now protrudes, perhaps breaches the endothelial cells to be at risk for a thrombus. And we're going to spend a lot of time saying over and over again in the next chapter that a heart attack is not just advanced atherosclerosis, it's also an imposed thrombus, and that's a totally separate process. So let's look at the growth mechanisms. First we had lipid accumulation, then we had collagen and chronic inflammation around it. Now we're actually talking about thrombosis, hematoma. Now, could you imagine maybe that wall is significantly weakened as well? Yeah. You think that that weakened might cause it to expand under normal arterial pressures, like an aneurysm? Yeah, so these are all things that are associated with advanced atherosclerosis as well. The thing to remember is that you know that basically only old people die of atherosclerosis, but young people, kids, even kids that are teenagers, start to get it. So when you work for the medical examiner's office, which I have for a while, and you're basically autopsying people that died of unnatural causes, you know, the people we talked about in the last chapter, homicides, suicides, perhaps teenagers, perhaps younger than teenagers, you're going to always see a little bit of this fatty streak and maybe even atheromas. Okay? Now, it's clinically silent up until the point at which there's a actual anatomic bump. At that point, that bump can result in blockage or stenosis. It could result in thrombosis, and that's when they become clinically overt. Now, you want to make it real simple? The earliest thing is the fatty streak due to deposition of cholesterol through the intima, or through the endothelial cells into the intima. Then at the point you can feel it, it's called plaque. Plaque may have calcium and collagen. And then the latest stage is that this plaque can cause enough damage where it's actually causing a thrombus. And by that stage, thromboses of arteries can cause infarcts. And we dealt with that concept as well under hemodynamics. Here's another way of looking at it, perhaps more pictorial. Here's your normal artery. Here's your fatty streak. There's no way you could feel a fatty streak. You could only see it. It's just like a little yellow discoloration, a streak, non-palpable streak in an artery. And of course, when you can feel it, it's called plaque. And the reason why you feel it is not only is there increased lipid in it, but there's perhaps increased fibrous tissue and calcium as well. Okay, so the more smooth muscle cells that migrate to the intima, the thicker it gets. The more the lipid, the thicker it gets. Now, in the transition from fibrofatty plaque to advanced vulnerable plaque, and vulnerable means at risk for thrombosis, you have things happening like further growth of the plaque, perhaps a lot of cell death and degeneration and secondary inflammation, and also a concept that we'll deal with which is called recanalization. Even though this lumen may be occluded or largely occluded, there can still be a recanalization, or the formation of endothelial cells through the plaque to continue the growth. So here are the clinical phases. After advanced, that wall can be so weakened it could rupture. But not only can it rupture, it could balloon out before it ruptures. Another thing is it could be completely occluded by a thrombus, or it could just be very, very, very severely stenotic. So, does stenosis usually precede thrombosis? Yes. Does aneurysm, is that usually preceded by weakening of the wall due to this process within the wall? Because by now, it's not the media that's the thickest thing of the artery, it's the plaque that's the thickest thing. And even though the media The intima is basically involved. Look, it can extend almost all the way through the entire thickness of the blood vessel. Now, I don't know if you've seen many arteriograms, especially coronary arteriograms, but you'll see radiologically that there's been a stenosis of an artery, and your uncle goes into the hospital with chest pain, and he says, "Oh yeah, you have a stenosis. You have to have a stent or a bypass or whatever." And the rule of thumb, remember, when you look at arteries, you're looking at not all 3 dimensions. You're looking at 2 dimensions. You don't know the full diameter of this compared to the normal diameter, but the general rule is stenoses are generally symptomatic if they're greater than 90%. That's why you could be walking around right now, I could be walking around right now without any chest pain, hiking 30 miles, through cattle moraine, and still have 90% stenosis of my coronary arteries, or critical parts of my coronary arteries. So 90% is generally a rule that they use. Stenosis greater than 90%, you're probably going to be having significant symptoms, even if there is no occlusion or aneurysm or rupture. So let's take some more morphologic concepts, the things you can see grossly and microscopically. Well, I'm going to show you pictures of macrophages, which are monocytes after they've migrated through those endothelial cells. And because they have fatty substances, cholesterol esters, other fats, they infiltrate and accumulate. So there's intimal thickening because these cells are accumulating lipids. Okay? If you could only see it, that's good. It's a streak. This might be in a teenager. If you could feel it, probably beyond the teenage years, as a bump, because this lipid accumulation and perhaps secondary fibrosis is now palpable. That's called an atheroma. You can also call it a plaque. An atheromatous plaque is exactly the same as an atheroma. It's also the same as generally what they call plaque. Plaque has different meanings. We saw plaque in Alzheimer's disease, but when I talk about plaque in arteries, they're referring to atheromatous plaque. You can see not only smooth muscle hyperplasia, but you can see the smooth muscle involving more and more of the intima rather than being contained to its media. You can see secondary fibrosis, you can see calcification. If there's weakening of the wall, you can physically see dilatation of the wall due to the same amount of pressure causing a bulging or ballooning of the lumen. And of course you can see thrombosis. So we've seen plenty of those in labs as well as in chapters. Here's some nice pictures. This is a part of pathology you probably expected to see. Here is probably, I don't know, I think this could very easily be an aorta of a teenager. It looks pretty nice. But do you see how it's a little more yellow, like along here, and especially near the openings of the large elastic arteries? Well, if you were to be a little man, with this pressure meter, for some physiologic reason, which probably only a physicist knows for sure, the part of the aorta which has the brunt of the pressure is the opening of the large arteries. So that's the area where you're first likely to see streaks and plaque. Now you're probably thinking, whoa, well, Dr. Minarsik is telling us that hypertension got to predispose to atherosclerosis as well. I wonder if that's a major risk factor. Well, you'll see. Also remember that here we have an area of aorta that's even more damaged. Perhaps there's some intimal hemorrhage. Look, where does it occur? It occurs at the opening of the large elastic arteries. Perhaps I don't know if this is an innominate or a subclavian or a carotid or whatever. Here's a fatty streak now, and you can see that this really represents these foamy macrophages under a nice thin layer of endothelium. And I know what you're thinking. You're thinking, well, is this the endothelial cell? No, this is the endothelial cell. Look, you see that nucleus there? 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 Those are endothelial cells. Look, it continues. There's a nucleus, there's a nucleus, there's a nucleus. It's right subendothelial where you get your foamy macrophages, formerly monocytes. Okay, here's a more graphic, diagrammatic point of view. Here is your dividing line between media and intima. Okay, here you can see that there has been not only some increased lipid deposition in the extracellular matrix in general, but you can see a lot of them, much of it, is still within the cytoplasm of these macrophages. These are the foamy macrophages. Sometimes the cholesterol crystals out. Okay, these are cholesterol crystals. They have sort of a needle-shaped appearance. They're called cholesterol clefts. So we're going to see some examples of those as well. So you see foamy macrophages, which you generally get before the clefts. You can see pools of lipid. You can see that a lot of these smooth muscle cells are now in the intima. And you can see that the monocytes have just undergone a name change operation, and they have now become macrophages by virtue of transversing or breaching the line formed by the continuous layer of endothelial cells. So, you want to call this a necrotic center? Yeah, you can. There's cell debris in there, there's cholesterol crystals, there's cholesterol cleft, there's foam cells, and there's free calcium. You want to call that the fibrous cap? Now I know what you're thinking, is that why do you call this a fibrous cap? These are smooth muscle cells. Well, remember, they can make collagen. So collagen is the main component of fibrous anything. But in addition, there's going to be some mixture there. It's never quite totally this neat. There's going to be increased ground substance. There's going to be perhaps formation of new blood vessels, because remember, this is an inflammatory response, so there's a new blood vessel. There's some neovascularization. End result, this is a plaque, and that's what constitutes a plaque. Now, I'm going to ask you the world's easiest question. You know, I was thinking of not popping open the question window, but I'll do it anyway because I know you all get the right answer. Which one is worse, the right one or the left one? Everybody knows that. I got the answer there as well. Yeah, the right one is worse. Why? Because what are some of the things that we see on the right that we don't see on the left? Well, you see ulceration of plaques. That's why it's red, because it's been ulcerated. So there's already some blood clot forming on there, isn't it? You can see that there's more plaques. You can see that there's bigger plaques. And the only reason why it doesn't look yellower is because most of these yellow areas are now replaced by plaques. Overall, this thing probably has about, 3 times as much calcium in it than this one, quantitatively speaking. What are the advanced features of atherosclerosis? These are all logical. This is right from the book, but by this stage, I think you should see they are all logical. Well, the artery can rupture because the wall is weakened. You no longer have that nice rubbery, elastic thing. The elastic fibers, may be infiltrated by plaque and fibrosis. You no longer have that nice rubbery band type of consistency. And literally, when you take the aorta of a young person and, at an autopsy, and there's little or no atherosclerosis, that thing is like a rubber band. You could almost like zap your PA with it, snap them with it. Not that I've done it, or maybe I've been tempted to do it. Another thing that you could do when it's advanced or even mediate atherosclerosis, you'll lose that sense of elasticity. I wish there was a test, an autopsy, to measure elasticity, but it could weaken to the point where it's actually ruptured. We saw in the previous picture that the plaques can become ulcerated. Once it's ulcerated, the blood and the platelets are directly exposed. They're no longer protected by the endothelium. So now you have a seeding for thrombosis. Another term, which is probably identical to ulceration, is erosion. So an erosion of a plaque is probably the same as an ulceration. You can get atheroemboli. In other words, not only are you now forming blood clots on that large artery or aorta or branch of the aorta, but these little fragments of plaque can embolize. And I want to tell you something right now. We're going to see it several times in this course. An atheroemboli can be differentiated from a venous emboli as if there's calcium in it. You know, in a venous emboli, you just have blood clot. In an atheroemboli, which travels away from the heart, as opposed to venous emboli, which travel towards the heart. In atheroemboli, you can actually sometimes see fragments of cholesterol crystals and foam cells and calcium. These are not things you usually see in venous emboli. You can have hemorrhage within the wall of this structure. The hemorrhage can dissect, in other words, travel through the planes of the wall. Those they call dissecting hemorrhage. You can have a big thrombosis. Finally, if the wall is weakened enough, you can have a bulging of the wall, and that's called an aneurysm. So let's go to a mini lab right now and look at some of the things we've been talking about. This is not from any of our lab cases. These are actually pictures I Googled. But here's a trichrome stain. And let's say that this part of the arterial wall is the relatively normal part. You can see here's a big plaque. And you could see, here, I'm going to ask you a really nice question here. And I know you're all going to probably be close to getting the right answer. I'm going to ask you, what percentage of the normal lumen of this artery is stenotic or reduced by this big plaque? Okay, I'm seeing things ranging from 50 to 75, and I probably would have said 60 myself, and actually a couple people did say 60. So you got the general idea. Now, can I ask you another question, theoretically? When a cardiologist does, two-dimensional arteriography, let's say that he's looking from this point of view. He might think that the lumen is, 80 or 90% narrowed. But let's say he's looking from this point of view. He might think it's only 50 or 60. So that's the disadvantage of just looking at an arteriogram from the point of view of two dimensions. And also remember, this might be a 60% stenosis, but another centimeter or two down the line, it might be a 20% stenosis or a 90% stenosis, right? Okay, so this C could be considered the core of lipid. This is a trichrome Masson stain, so the blue stuff is all collagen. I think you could recognize the pink stuff as being smooth muscle, but look how that smooth muscle is present focally, like here and here, within the atheroma as well. What would you call this little thing over here? Yeah, you know what? I'm going to open up the question box again, because this is a tough question. What if I told you that in the middle picture it was a elastic stain? So I'm going to ask you once again, what do you think this little black line is? Yeah, it's the elastic lamina. Now let me ask you this. You think it's the internal or external? Well, you all know that it's the external, because I see you got the answers already. But do you see how it's disrupted over here? And of course, the internal, perhaps that might be it. It's completely disrupted by this large plaque. Now, in the third picture, let's see if I want to ask you some questions here. Yeah, let me ask you this. No, that's not a fair question. What do you think most of these cells are over here? They have a nucleus, but there's a lot of clear cytoplasm around them. Yeah, those are foam cells. You all know that. Here's a tougher question. You see this little skinny arrow right here? What do you think this white thing is here in the extreme northeast? It's a tough question. Somebody said fat. I gotcha. It's actually, another blood vessel. I'm pretty sure it is, because if you look, you can see probably tiny nuclei. So remember, this is the neovascularization. Now, I'm going to ask you the world's most unfair question right now, only because I'm not sure myself. I'm thinking this is so dark, and part of it is chipped out, that might be calcium. But I think it's more likely that real tough, darker stuff there is a little bit of calcium. And I would guess that, what would you probably call these cells at the tip of these two arrows, which are not foamy and they're not calcified and they're not blood vessels? Call it something really, really boring, like, yeah, you got it, fibroblasts, maybe smooth muscle too. I'd call it a fibroblast myself, and I can see most of you are, so you're getting to be as smart as I am. I'm getting kind of worried. Let's go to the next thing here and talk about the epidemiology and risk factors. You know, I wish I could sit here today, 2012, tell you this is specifically what causes it, but let's talk about risk factors instead, because we don't know one single thing. It's related to the development of a nation. I don't know if you want to call it nutrition or overnutrition or gross national product. The nations which are so-called highest development, whatever that means, these are the ones with the highest epidemic of atherosclerosis. U.S. happens to be about the highest in the world. Why? Because we like to think that we're the most developed. Well, you know that's not true, but you know we like to think it anyway. There's been a more than a slight decrease, you know, in the last 40 years, 50 years. And why is that? Probably because finally they took a lot of the stuff that we know, like cholesterol and trans fatty acids, out of the diet, and also because there's more of an awareness. And remember, that's independent from the newer methods of treatment now, like stents and bypasses and so forth. So there's actually been some improvement, mostly due to education and awareness. You know, you can't really change people's lifestyle, but what the government can do is take a lot of that crap out of the foods. You know that we said that the average age of starting or onset is as a kid, but we know that the average age of somebody with, let's say, a heart attack, or less specifically an arterial clinical event, is probably somebody in their 50s, 60s, you know, and plus. The thing to remember is that women generally don't get atherosclerosis quite as early as men do clinically. I mean, they both start it when they're kids, but the cardiologists and the pathologists talk about the so-called protective effect of estrogens. And that would be the reason, is that once a woman reaches menopause, let's say 50s, okay, as a rough thing, she then is going to be about the same level as a man. And a man is already probably more advanced in his 50s at atherosclerosis. Of course, once you go 10 or 20 years later, they're both about the same. So there's so-called protective effect of estrogen, even though we had noticed in one of our recent sessions is that increased arterial events are one of the side effects of some of these compound estrogen compounds. Of course, genetics is a big thing, very, very complex. I wish I could say there was one gene, but you know, it's not really a genetic thing per se, other than the fact that it follows the multigenic principle, with which a lot of diseases do. In other words, the more relatives you have that are closer to you that have had atherosclerosis, the more likely you are to get it. And that's really nothing you can change at all, no matter what your diet is, no matter what your exercise is. So here we go. We're going to tell you the cause. I lied. We're going to tell you the risk factors. There's no one specific cause. We've already pointed out hypertension, risk factor, hyperlipidemia of any type, not just hypercholesterolemia, abnormally high lipids of any fraction associated with it, cigarette smoking, without a doubt. The heart surgeons will tell you that if you don't have diabetes and you don't have hypertension, your arteries got to be this bad shape because of genes and cigarette smoking. And of course, their diabetes. And the relationship between diabetes and atherosclerosis is so intimate is that the more conferences I go to on diabetes, I really think it's atherosclerosis. And the more conferences I go to on atherosclerosis, I really think it's diabetes. So I'm at the point where I'm almost thinking they're the same disease, even though technically, in regular old atherosclerosis, we shouldn't be having, islet cell problems. So, isn't it interesting that of these 4 major risk factors, they can all be controlled, can't they? You could take things, statins, to reduce your lipids. You could take things to reduce your blood pressure. You could quit smoking or never smoke or stop smoking. And you could have your diabetes under the control as well. So isn't that interesting? Every single major risk factor can be controlled. Isn't that nice? Of course, your genes can't be controlled, but all these risk factors can. And this is the beauty of the Framingham study and the things that followed it. It became very, very clear that even though, you could walk down the street and you'll have some joker tell you that he got a 5th risk factor or something that's just as important, it'll all be baloney. These are the really 4 big risk factors. We're going to come up to them. We're going to deal with each one. And remember, here they are, the 4 big ones. They're all modifiable. Here are the non-modifiable ones. Of course, you can't do anything about your increasing age. You can't do anything about being a man. I guess if you're a woman, you could take your estrogens longer, get hormone replacement therapy to prevent menopause. But remember, we said that there is a little bit of an increase in cardiac disease with them. You can't do anything about your family history, which is your genes or your genes. However, let's look at some of the minor risk factors. Not one single minor risk factor is as important as a major risk factor, but they're largely modifiable. Obesity is a minor risk factor. Physical inactivity is a minor risk factor. The so-called stressed or type A personality, I don't know, I guess that can be treated somehow. Estrogen withdrawal can be postponed, okay? High carbohydrate intake can be modified by diet. And we know that alcohol is a minor risk factor. And I'll tell you, if there's anybody out there that says, well, I heard from a doctor that a little bit of alcohol is good, I want you to leave this class right now, because that's the single greatest lie ever strewn upon the civilized world. There's another type of deficiency of a lipoprotein. It's an abnormal type of lipoprotein called lipoprotein A. That's associated with increased risk of atherosclerosis as well. But it's not a major, it's a minor one. Also, the dietary things, unsaturated fat, trans fatty acid. These are all things which are very easily controlled. Now, let me tell you another thing. We always thought of atherosclerosis, and we still do, as being a degenerative disease, remember? So of all the chapters of Robbins, we're going to spend the most time in this chapter talking about degenerative diseases. And all the other chapters, we're going to be talking about more neoplastic and inflammatory diseases. However, chlamydia is a well-known organism. People get chlamydia, okay, which is known to damage endothelial cells. A lot of the chlamydia infections can be subclinical, so it's very possible that there's a lot of damaged blood vessels out there. Not all of them is because of a chlamydia previous infection. Now, do you want to know what the big virus is? I guess I could make you guess, but I'm too lazy to pop out that thing. CMV is also something that has a predilection towards injuring endothelium as well. So one bacteria or obligate intracellular thing that's like a bacteria, one virus. And does that mean we have completely blown our theory of this as being a degenerative process? Or are we saying it's really an inflammatory or infectious process? I don't think so, but there's a lot more work to be done with it. Here we go. I'm not repeating this again for no reason. I'm repeating it because I want you to write it down and go to the tattoo parlor tonight have them put it all on you, because I don't want anybody ever telling you or making you believe that there are other risk factors that are major. Here's the first one. Hyperlipidemia, chiefly cholesterol. You know, the bad cholesterol, the LDL is bad, the HDL is good. So the higher your LDL is, you know, the worse you are. The higher your HDL, better you are, because HDL mobilizes bad cholesterol from the plaque into the liver. Low cholesterol diet is generally good. Unsaturated fatty acids in your foods, generally good. You know, I personally take a couple of the omega-3 fish oils every day. I don't know, I guess I believe it's good. I like them anyway. It's not going to hurt, and it's just a habit I had for many years. Exercise is good. You know, that raises your LDL. We all know that. Okay. Now, you want to know something that's kind of weird? I don't know if I'm going to show you this picture yet. Oh, I think I showed it to you in the before. Is that not only will increased serum cholesterol and cholesterol esters, compounds, lipids, be in the foamy macrophages and perhaps go into the artery, but it'll also come out. So a lot of these big pools of calcium inside our arteries, they go back out into the blood. So most of your cholesterol in your artery is going into the plaque, but some is coming back out. Now, here's the best way to visualize calcium in a plaque. You already know that these nice little slit-shaped substances are pure cholesterol crystals, cholesterol esters. So if I say cholesterol, okay, but what about these cells up here that are, you can see a nucleus, you can see it's kind of a lighter, foamier cytoplasm. And look, I actually took a couple of snapshots from our one of our lab cases, and here's some more what looks to me like fibrous tissue. Maybe some of these are smooth muscle cells, but they look more like fibroblasts to me. You can see some of these cells are surrounded by fat, and the reason why it's fat is because the fat isn't there. It's just white. It's a clear space. It's been washed out by the processing, so the space is just as clear as this blood vessel is over here. So these are typical appearance of foamy macrophages, and I'm going to show you another snapshot I took from our one of our lab cases we're going to see. Here's some more. They don't have to be all that foamy and granular. They can be very subtle. Like when you look at these cells here, they look at just a little bit of white substance surrounding. Those are foamy macrophages. Here are some which are a little bit foamier, and as expected, the fat is washed out. Okay, so here's the question. I'm going to pop open the window again, and I know you're all going to get the right answer because you understand the process. Here's the question. We just talked about the cholesterol being in the foamy macrophages up here and the cholesterol crystals down here. Now, here's the question. What do you think comes first? Yeah, the macrophages. I know you got it right. A lot of you didn't answer. Before you can actually build it up as crystals, you're probably going to be having it. So in the very, what do you think a fatty streak would have more predominantly? Foamy macrophages or cholesterol crystals? The earliest form. Yeah, the macrophages. Okay. Now I know you're all learning this stuff, and we'll go on. Here are our risk factors. Whoops, I'm sorry. Here's some more cholesterol clefts, a blower thing. There's nothing else in the body that looks like this. And in addition, when you see cholesterol clefts with this classical cleft-like appearance, you know it's not a cut artifact. And you know you're probably dealing with the inside of a plaque. And you know, nobody likes to look at plaque. They're kind of boring. So we generally ignore these cholesterol clefts. But if you look carefully at cholesterol clefts, like maybe here, and some of the cells around them, like here, and you see some of a granularity or foaminess to the cytoplasm, you know that there's a lot of cholesterol there too. Here's a picture that shows the risk factors. The first one we talked about was cholesterol, but as you can see, as your cholesterol, we're going to use the value now of 220 being about normal. As it goes up from 220, 260, your risk of an ischemic heart disease goes up as well. So these are all the risk factors put together, however. So if you have a person with a normal blood pressure, a normal cholesterol, a normal HDL cholesterol, which is normally, hopefully, high, and doesn't have diabetes, and doesn't smoke cigarettes, then let's just say by whatever number, we're just going to say that here's that person's risk. And as you can see, men are a little bit more at risk than women. But let's put in some of these additional things now. Now you have somebody, the blood pressure has gone up to 160 systolic, the cholesterol has gone up to 260, the HDL has gone down to 35. Now we got diabetes present, and let's say the person's a smoker. Well, if you're saying that person with none of these risk factors has about an 8, 7, 6 risk, look at this. We're going up to almost 10 times as much, aren't we? So these are the real statistics. This is not a rule of thumb. This is a real good study that was done, and I can't remember where. Let's talk about the second risk factor, hypertension. Hypertension causes atherosclerosis, and atherosclerosis causes hypertension. Well, why does hypertension cause atherosclerosis? Because arterial walls that are subjected to greater amounts of pressure than they should have are damaged endothelially simply by the increased pressure. Now let's take the flip side of the coin to make this a vicious cycle. How does atherosclerosis now cause hypertension? Well, remember I told you that in the nice normal, theoretically, aortas are nice and rubbery, they're nice and pliable, they're nice and elastic. Well, what happens to them when there's atherosclerosis in general? They're less rubbery, they're less pliable, they're less elastic. In fact, I'm going to show you disruption of elastic fibers as well. That artery becomes stiffer, and therefore greater amount of pressure. So we're talking about a vicious cycle here. Nevertheless, when you look at the fact that hypertension is a major risk factor, or causes it if you want, this is the reason. I don't want to say anything more about cigarettes as our third risk factor. You know, we already said a tremendous amount about it a few days ago on the environmental. Let's just say that we know a smoker, as one of the risk factors, puts himself at a several-fold increase for clinically significant atherosclerosis event, like heart attack, stroke. The sad thing about it is that it's 100% controllable. But that's easier said than done, isn't it? What about the fourth one now? Diabetes. Well, we all know that diabetes is caused because of either not enough insulin from the beta cells, or perhaps more likely increased insulin resistance. We all know that it's a disease of the pancreas. But when you look at the clinical effects of this disease, I have a very, very, very hard time differentiating from atherosclerosis. I used to have a standing bet with my students, and so far I never lost. But really, I'm at the point where I'm thinking that diabetes and atherosclerosis are basically the same disease. The thing that keeps pounding me in the head is we don't normally think of regular old atherosclerosis as being due to lack of insulin. Well, guess what, folks? Regular old adult onset diabetes, or diabetes 2, is generally not so much a lack of insulin either. It's increased resistance to insulin. So we've got two diseases here. We think they're different. We generally know each one. We're going to spend we've already spent a lot of time on diabetes. We're going to go to it again under the pancreas chapter. But we're talking about what I believe, if you want to call me crazy, you can, is probably, if not the same disease, very, very, very intimately wrapped up as one. Let's talk about some of the major Non-major factors, okay? You could probably make a list of 20 or 30. But let's talk about the non-major factors, the common ones. You know, there's a genetic disease called homocystinuria, and the reason why you're getting homocysteine spilling off into the urine is because there's too much of it in the blood. There's homocystinemia, and that's because of a deficiency of a specific enzyme, which I put down here, called CBS, cystathione beta synthase deficiency. It's a genetic disease, but it also can be aggravated by low B6 and folate intake. You know, vitamin B6 is often given for a lot of atherosclerosis, whether the person has homocystinuria or not. We know that somebody who coagulates easily, we talked about the chapter on coagulation, all the factors resulting in coagulation before it should take place. We know that's a minor factor, but remember, it's not coagulation itself. It's coagulation on a atheromatously damaged artery. That is the clinical effects of atherosclerosis. There's a lipoprotein called lipoprotein A. Some people have it. I think Asian people are more likely to have it than Caucasian people. It's a little bit altered chemically as form of LDL, but there's an increased risk there as well, but it's not a major factor. You know, there's a common knowledge that people that don't exercise, maybe it's related to obesity as a cause or effect, they're at risk. So-called type A personalities, you know, it's not a major factor, it's a minor one. So does a type A personality lessen his risk if he receives medicine or some kind of therapy which, you know, chills him out a little bit? I don't know, but the one thing that doesn't work is alcohol, because alcohol is a minor risk factor. Now, you know, every time this is dealt with at a conference, there's somebody in the audience, or, you know, maybe the professor that says, well, you know, there was a study in France that showed that red wine, you know, and let me tell you, I want to use a very common American term. It's called bullshit. It means whenever you hear that a little bit of alcohol is good, that's a lie. Okay, because the only thing a little bit of alcohol ever led to was more alcohol. So usually when somebody presents us at a conference, they're probably a closet boozer. Okay, end of topic. Now, this is the part that's going to look a little bit repetitive again, because now we're going into the pathogenesis. I'm going to be repeating largely what we said under nonspecific injury as well as natural history. This is not my quote. This is a quote from, I think it's Robbins, because it's a very, very profound statement. As far as we know, the pathogenesis of all atherosclerosis cannot happen unless there has been some injury to the endothelium. I wish we could find out if there was one thing. All we know are the risk factors. But the facts are, if you don't have injured endothelium, whether it's by chlamydia or cigarette smoke or hemodynamic or hypertension, or atherosclerosis does not occur unless you have injured endothelium. So here's the saga. Here's the saga in my own words. You have injured endothelium chronically, okay? We all know that the monocytes, now macrophages, come in, build up the cholesterol in the wall, chiefly the intima. We now have some oxidation of those lipoproteins, okay? So when you hear that a certain type of berry juice or something, nowadays in America, when they want to charge twice as much for something, they say it has antioxidants in it. So the Americans, fools that they are, reach into their pockets and they gladly pay twice as much because the FDA allowed them to use the word antioxidants. Now you got the migration of monocytes into the endothelium. Now remember, I told you before that that was the very, very earliest step that you could see microscopically, and it is, because all of this stuff now is non-detectable by usual techniques. Now you have a building up of the plaque. We have smooth muscle activation. You could even have platelet adhesions because of this injured endothelium, proliferation of smooth muscle and lipids within the matrix, and this is the saga. It's a rather linear chain of events, okay? In other words, every one of these little bullet points doesn't usually happen unless the previous ones do. And remember, by the time those monocytes migrate in, there's already been oxidation of lipoproteins, there's already been some cholesterol in the wall, and there's been some absolutely, the very earliest thing, chronic endothelial injury. Okay, I'm looking at our clock. I didn't realize I was yakking so much. We're already a minute afterwards. Sorry for rambling on and going on, but we're making pretty good progress here. I thought we could do all of atherosclerosis in one session. I see we can't, but what we can do is open up the box